Thank you for your kind presentation, and dear chairmen, dear colleagues, thank you for having me here today. And so in the last session, we go back to the past, because actually Brugada syndrome is our heritage. And I will talk about atrial fibrillation in Brugada syndrome. So we know since the first paper by Pedro and Josep Brugada in 1992 that patients with the Brugada syndrome have a lot of different arrhythmias, and atrial fibrillation and supraventricular arrhythmias are part of the syndrome. We know that patients with the Brugada syndrome have a high prevalence of supraventricular tachyarrhythmias, frequently is atrial fibrillation. And the incidence of atrial fibrillation is between 9 and 53% in this population. So we asked ourselves why patients with the Brugada syndrome have this high rate of atrial fibrillation and of atrial arrhythmias. We evaluated this with our group in Brussels with the ECG imaging. So what we did, we used the 252 electrodes vest we placed on the torso of the patients, and as you can see here, we can reconstruct the unipolar EGM from the cardio insight. And we analyzed the atrium. So we analyzed the biatrial map of control patients and of Brugada syndrome patients. So up, you can see a control, you can see an activation map, biatrial map of a control patients, down Brugada syndrome patient. And what we measured is the tact and the lact. So the tact is defined as the time interval between the start of the first electrogram of the first atrial activation to the end of the latest EGM of the latest region activated in the left atrium. So it's a biatrial conduction time and is calculated from baseline crossing to baseline crossing. Lact is the local activation time, so it's defined from the steepest negative EGM of the first electrogram in the right atrium to the steepest negative DVDT of the latest EGM in the left atrium. So these are actually transatrial conduction time. So it's the time to go from the right atrium to the left atrium for electrical activity. And what we found, as you can see here in the box plots in the middle, red is a Brugada syndrome and blue is a control group. So the tact is significantly higher in Brugada syndrome compared to control. So Brugada syndrome patients have a slow conduction in the atrium. Also on the right, local atrial conduction time is longer in Brugada syndrome compared to control. So again, in Brugada syndrome, we have slow conduction in the atrium. And what we looked also was what is the effect of Ashmalin in these patients on tact and lact. So we compared before and after Ashmalin, and again the results are not surprising. In patients with the Brugada syndrome, the tact and the lact are both higher after Ashmalin, because actually Ashmalin blocked the sodium channel, so we have a slower conduction after Ashmalin. And also what is even more interesting is that we analyzed the predictors of atrial fibrillation in Brugada syndrome. And we saw that left atrium dimension and the tact were predictors. And we also found a cutoff of tact more than 138 milliseconds. And this can be used to stratify the risk of atrial fibrillation in this patient. And this is a non-invasive marker, a non-invasive risk stratificator for this population. What about the prognosis of patients with Brugada syndrome and atrial fibrillation? The group of Fiorenzo Gaeta from Turin, they analyzed three groups of patients with Brugada syndrome. So group 1, atrial fibrillation, atrial flutter documented after diagnosis of Brugada syndrome. Group 2, when Brugada syndrome was unmasked for the first time after class 1C therapy. And group 3, so Brugada syndrome without atrial fibrillation or atrial flutter. And what they saw is that the group 1, so patients with atrial fibrillation, had a higher rate of ventricular events. And so we asked ourselves, what about the genetics? So patients with the SCN5A mutation, we know that is in 20% of patients with Brugada syndrome, we can find a pathogenic variant in SCN5A. And we know that this is associated with a higher risk of ventricular arrhythmias. What about atrial fibrillation? So we recently published this 30-year experience from our center. And the answer is that actually patients with a variant in SCN5A have the same risk of atrial fibrillation compared to patients without a pathogenic variant in SCN5A. So there is no increased risk of atrial fibrillation. And why is important atrial fibrillation in Brugada syndrome? We have different therapeutic challenges. First is the anticoagulation, then inappropriate shocks, and the rhythm control. Let's see anticoagulation. Again, this is a study from our group, and we were the first to describe the abnormally high risk of stroke in Brugada syndrome. The incidence of stroke in patients with the Brugada syndrome and atrial fibrillation was unexpectedly high, was around 13-14%. And these are patients with the low CHA2DS2-VASc score, and 82% of them had the CHA2DS2-VASc score between 0 and 1. In 63% of patients, the cerebrovascular accident was the first manifestation of Brugada syndrome, occurring before the diagnosis. And this is also a study from our group when we saw the long-term outcomes of the ICD in Brugada syndrome. And we observed that in 36% of patients we had inappropriate shocks. And new onset atrial arrhythmias accounted for 13% of these shocks. And we saw that in multivariable Cox regression analysis, new onset AFib was a predictor of inappropriate shock. So that's why it's important, atrial fibrillation. And it's important to know because there are strategies to reduce the inappropriate ICD therapy. And after our study and the study of other colleagues, we now recommend the dual chamber device in these patients. Also optimal programming of ICD with a single high rate VF zone above 210 or 220. And of course, on monitoring systems to detect earlier eventually a lead failure. And of course, for rhythm control, these are difficult patients because most of the drugs that are used for rhythm controls are proarrhythmic and are contraindicated in these patients, especially class 1C drugs. So, of course, catheter ablation is the mainstay of the rhythm control in patients with the Brugada syndrome. This is our first experience with the pulmonary vein isolation in patients with the Brugada syndrome. It was 9 patients and 6 patients had an ICD implant and 3 inappropriate shocks. And we observed that 2-year follow-up, good outcomes with 67% of patients free from antiarrhythmic drugs. We expanded this experience with the 23 patients with the Brugada syndrome, and again, PVI after 36 months, so 3 years, 74% of freedom. So again, good results with ablation in this patient population. And these are the Kaplan-Meier. And finally, recently we published this, that is the largest experience in atrial fibrillation ablation in patients with the Brugada syndrome. And we compared the 60 patients with the Brugada syndrome versus 60 patients without Brugada syndrome, so controls, so with the propensity match. And what we did, we compared the outcomes. Actually, patients with the Brugada syndrome, as you can see in the Kaplan-Meier, they have a higher risk of a recurrence after PVI compared to patients without Brugada syndrome. And this is mostly related to higher risk of atrial tachycardia more than atrial fibrillation. However, the ablation was useful to reduce dramatically ICD inappropriate shocks. As you can see, before ablation, 27% of patients had an inappropriate shock, while after ablation, only 1 patient had inappropriate shock. So, in conclusion, a specific atrial substrate can be found in Brugada syndrome. And the delay in atrial activation and ECG imaging may be used for risk stratification of atrial fibrillation. Atrial fibrillation in Brugada syndrome is associated with a lower success rate. However, it should be performed to reduce the risk of inappropriate shocks. Thank you.
Thank you, Luigi.